sure there will be
that,
people who will be interested.
yeah, I've got to get that. Yeah, we'll have a couple of us. Yeah, we'll be working that out in the next 10th, I think that is.
10th, okay, we can do that, sir. Okay, so we can start in a minute. So just to be sure, so it'll be you first, then Dr. Mary, and then Dr. Princey, right?
Yeah.
Yeah.
Is that okay, Princey?
Yeah,
She's there?
also getting. She's
Okay.
probably.
All right. I think that should be okay.
Right. Perfect. Just checking if the stream. Okay, the stream we are live on YouTube also now. So welcome everybody. Thanks for joining the session. We have a few more people joining, but we're going to start in interest of time. And we have a very interesting panel today. To start off with, I'm going to introduce Dr. Russell D'Souza, who is the head of the Asia Pacific Division and the Director of Education of the International Program of UNESCO Chair in Bioethics, the University of Haifa. Also the Directorate of the Asia Pacific Division and Education Department at Melbourne, Australia. Moreover, he is the Executive Director and Dean of and a Professor of Organizational Psychology Medicine at the Institute of Organizational Psychology Medicine. And he's been with MSAI for almost half a decade now, and it's because of his efforts that we have a unit, bioethics unit within the organization. And he continues to support the chapter wholeheartedly. So you have the floor.
Can you hear me?
Yep.
Thank you, Purva. Thank you very much for your kind introduction. And I'm delighted to be here. For all of you from MSAI members and beyond, I want you to know that the UNESCO Chair in Bioethics has about 250 units around the world. We do have an MOU directly with IFMSA. I represent the UNESCO on the IFMSA board and with the liaison, and I have been attending many or some or most of the general assemblies. Now, of the 250 units, as it were, there is only one medical student unit, and that is the MSAI. If you go and look at the web page of the UNESCO chair, this around 250 units or centers are spread out in 58 countries across all the continents. But actual unit of the UNESCO, only MSAI is the only medical student body unit of the UNESCO. So that's important, and we established this, all of us, Professor Mary, who heads the Indian program. We have this the largest program with around 80 centers. Now, we have had very active, and then there were times when it was not as active. And as you know, this goes along with every year you get, or every couple of years we get a new team and so forth. But I'm delighted that this time I'm here, right? We've been I've been in touch with with Purva, your president, and your secretary. And in fact, we look forward to having a robust program, including the international certificate course. We had two, which were done some years ago, and I think Dr. Purva has completed that. But we want to now, particularly because last year, with our effort, the bioethics curriculum was brought in. So all of you, and those of you, of course, who will be taking the USMLE and the FLAB and the MCQ, MSA for the Medical Council of Australia all these you will definitely need this and it will be useful. So with your president, we are trying to, and your secretary and your vice president international, we are trying to bring to put a course out exclusively. Right now 13 and 14 is going on, but we want to bring one separately only for the MSI. So listen, you'll get to know from your president and so forth about that. Okay, now today I'm going to be we're going to we are all in the midst of the once in a lifetime pandemic that the world is facing, and every day we are learning new things, right? And I think I chose to present and speak to you on an issue on looking at what did we learn, and no, not necessarily only from India, but what I'm going to be talking to you is about the dilemmas, the ethical dilemmas that we have experienced across the world from an international perspective. And that's what I'm going to do. I'm presenting to you. I'm here in Melbourne, Australia, presenting to all of you there. And that makes it even more important and in fact very delightful. So what I'm going to do is to give you, to try and have a brief review of what are the dilemmas we've faced from an international perspective. Some of them were directly, you've seen it in India too, but this is a reflection. And from that, I want to take you through, because you are the future, right? So we want to see what we've experienced, and can this be the a good reason for us to enhance what we've learned, to become to think of a post-COVID bioethics that will stand us good for the next pandemic or epidemic, as it were. So that's what I was going to do. So if we took, so as we've all known, few novel emerging infectious diseases have posed such vital ethical challenges dramatically and indeed so quickly as this COVID that we are experiencing for the last 5 to 6 months. But of course, ethical challenges in healthcare are common. Even when we are dealing with normal circumstances, that is because healthcare, we are in the job of responding to human suffering. But the pandemic has had a tremendous impact, rather differently, in that it has broken up well-known structures that provide security and guidelines on many levels, not only to us individually in our daily life, but indeed to society and indeed worldwide. So that's what has happened. So with that type of a situation, we have in the last months faced dilemmas, ethical dilemmas. Probably for the first time, we have experienced this for many of us, most of us, a lifetime experience. And what we've learned that these have raised urgent, heart-wrenching requirements trying to sort this out. So I'm going to take you through a few that stand out, and then come back to look at what do we know. Now, the first one, of course, is the issue about mandatory and voluntary interventions. Going back to the Public Health 101 non-pharmaceutical interventions, isolation, quarantine, social distancing, and closures. Now, when you look at this, we want to look at what do we see, what have we learned? In pandemics, such as the one we are going through, we are left to decide what interventions can we use, particularly when we do not have any evidenced or accepted antiviral supplies or vaccines. When this type of situation we face, we have to revert back to the well-known non-pharmaceutical interventions that encompasses the traditional public health strategies of isolation, quarantine, school closures, social distancing, banning of large gatherings, cancelling of public events, and restricting transportation, which all of you have experienced there. But what do we learn from this? Now we must remember that in some regions, experts remained concerned about what would happen if we have these type of isolation, quarantine, social distancing. So they were worried about the secondary issues and the unintended consequences, maybe your civil liberties, but importantly the economic issues. Okay, and you know countries that knew the effects of what was going to happen. There was no treatments, but they were rather reluctant to take the right decision. Yet such reticence runs contrary to the mission of public health and the common sense compulsion to act in the face of a potential destruction and death, as we have been seeing every day. What has the world gone through? How many million have been infected? What mortality, and so forth. Now, when we translate that into ethical terms, inaction can carry serious problems. In this case, what we say is violating the harm principle, which maintains that the individual autonomy can be curtailed to prevent harm and injury to others, and of course, disregarding the escalating social risk. So we see this as what we've learned, and I need to say that United Kingdom, Sweden, and USA were some of the places that they were considering, did not want to take this up. Some of them have now had to take it, but at a tremendous cost. And again, this is where the harm principle was impacted on. Now, what we learned from all this is two critical ethical questions emerge from what we've learned. Can communities apply these interventions that I've just spoken about in a manner that maximizes common good and minimizes negative social and economic consequences? And the next question is, what are the ethical implications of these interventions, particularly when it comes to balancing individual liberties with the need to protect the public's health or population health? So what we see is from this that in order that these can be done ethically, we have to have some ethical principles must be held as ideals. And what we've learned is, first, that these mandatory non-pharmaceutical interventions must rest on a foundation of public health science, coordination and cooperation, and not law enforcement. That's the first way it should be looked at, or embraced or implemented. Second, interventions such as we've just spoken about, quarantine and school closures, must meet the harm principle and conform to international ethical principles. And what are those principles? It requires that cohesive public health measures must be legitimate, must be legal, must be necessary, non-discriminatory, and represent the least restrictive means appropriate to the reasonable achievement of public health goals. And finally, the principles of transparency, non-discrimination, and indeed accountability, which includes the right to due process to challenge these mandatory non-pharmaceutical interventions, must be enforced. And I say this because we are what we see in the world. We are seeing the same these principles being used in Hong Kong to suppress the other issues that not so much as the public health, but from a political perspective. And this was brought up at one of our meetings. So these are important ethical issues. So what I'm bringing from you to you is what we have learned and what we have seen around the world. We talked about the harm principle in some countries not willing to take the public health requirement, and in other ones using it, but using it with a different purpose. And that's what we've learned in this from this pandemic. The next ethical issue I'd like to focus on is the public health emergency that we've dealt with, and we are continuing to deal with this. Global public health emergencies, usually they come up when the health system becomes stretched beyond its capacity and its ability to respond to a catastrophe, or then a global public health emergency is brought in and necessary. But it must be guided by ethical and legal frameworks. And what does that require? Very important aspect is distribution of scarce resources ethically, using a fair process. Because what we've seen from what we've experienced in this pandemic, globally low income countries will face much more scarcity than wealthier countries. That's something that we have seen, and we are seeing, and we are continuing to see. So that's one thing that we've learned. But what we've also learned is that wealthier countries are ethically obligated to assist. Why? Because even if the COVID is well controlled in a wealthier country, you see what is happening in Germany, what is happening in Spain. New outbreaks will become inevitable unless the other regions do as well. We are having this issue globally at the moment. We are all, and then what comes out from this is, we are all only as safe as the most vulnerable among us globally. And so the take-home message is, equity and public health go hand in hand. So, how should ethically sound healthcare during a public health emergency present? Importantly, ethically sound framework of public health during public health emergencies have an important focus to balance what we generally know as patient-centered duty of care, which is our clinical ethics, which is under normal conditions. But when it comes into this type of public health emergency, we have to balance this with the public-focused duties to promote equity of persons and equality of persons and equity in the distribution, not only of risks, but not only of benefits, but also risks. And this refers to the focus of public health ethics. So that's an important part. And on the other side, we see that an ethically sound framework for healthcare organizations during this public health emergency has acknowledges two competing moral authority sources, and these have to be held in balance. That is, the duty of care that is fundamental to all of us, fundamental to healthcare that we all vouch for, and that is the fidelity to the patient. And the other is the duty to promote moral equality of persons and equity. And this means fairness relative to need, in particularly in distribution of risks and benefits in society. Now, this is all the type of things that we've had to deal with, and we'll come back in the end to some of these areas. The next area I wanted to highlight is the humanitarian emergency that we have seen and had to deal with this pandemic. The world has faced a global humanitarian emergency. The social distancing, quarantine, and so forth, travel restrictions have imposed that were imposed to fight this virus has disrupted everyone's life. And when we look at that disruption, we see that it affects all segments of the population. That's what we've seen. But what we've also seen, it was particularly detrimental to members of the social group in the most vulnerable situations. And I think you're all aware of all the issues with the migrant labor and so forth that we saw that who had so much of having to traverse and manage this humanitarian emergency. And what we see from around the world, the affected populations seem to be people who are living in poverty situations, older, vulnerable persons, disabled people, youth, and in countries like Australia, United States, Canada, we have another vulnerable group, which is the indigenous people of that region or country. Our early evidence indicates that health and economic impacts of this COVID is being borne disproportionately by the poor people. That's what we, in the last 6 months, we will be able to see. And we see that, for example, homeless people, because they may be unable to have safely shelter in a place, they are exposed to the dangers of the virus when they don't have they're homeless. And if they didn't have running water, the refugees, migrants, displaced persons, all stand to suffer disproportionately, both not only from the pandemic, but indeed from the aftermath, whether it's due to lower movement, employment, or the increased xenophobia. The important aspect here is human solidarity. I want to highlight this and bring this to all of you to think about it. Human solidarity and cooperation is Article 13. It's enshrined in the Universal Declaration on Bioethics and Human Rights under Article 13. Now, the questions we'd like to ask is, how can we ethically engage with these affected communities, but at the same time remain accountable to them? Because we have this risk of exclusion and stigmatization of the vulnerable group, and this has become a very important concern in many countries. The rural poor have to choose between dying of hunger because they have to stay at home under the quarantine, or they die of infection because they have to go out and earn money to get some food. all these discussions are indeed a matter of human solidarity. Another important highlight here that we've learned, that we see as important, is human dignity and what is called the core humanitarian standard, which human dignity is referred to, is part of, and that is the United Nations called, they've developed what is called the core humanitarian standard. As the world raced to respond to this global pandemic, we learn now that it is important that we keep in view rights, dignity of people at the forefront of our work. People need to be seen as human beings, not just cases. And as I talked about, the core essence of the core humanitarian standard is human dignity. And we are at an unprecedented global public health emergency, which has not only economic crisis, it also has social crisis and severe restriction to movement, stretched healthcare system. In this type of situation, we find that civil societies, humanitarian organizations have come in to play a critical role when everything else is disrupted. So we must remember that we learned that all people should have equal access to health services and treatment without discrimination, and of course, they must be treated with respect. Another thing that's come out from this pandemic is looking at social networks. What is its role? How has this pandemic affected that? A factor that has been overlooked is the role of people's social networks and how these networks become compromised by this pandemic. We have good research that suggests in crisis, whether it be drought, for floods, famine, war, and so forth, people turn for help first to their social networks. And research in several countries shows that social connectedness is the main, in fact, it might be the only source of help that ordinary people have when they are caught in a crisis. But in this situation, this pandemic, what happens when the threat is embedded in that very social network? We asked to distance. What happens to the source of support that people have learned to count on when everyone's affected by a threat in terms of both their health and also their livelihood? And it shows a compromised social network is what we've seen. The current pandemic is an unprecedented situation where the survival resource of the most vulnerable people is their social network, and these have become compromised. And so it becomes an added burden, an additional risk, because why? Because this virus is transmitted between people, and so the social network is also impacted on. This has had massive implications for responses to this pandemic. And of course, how it will amplify the impact of existing humanitarian crisis is being rolled out. So the lesson we learn from this is that recognizing and protecting social solidarity is another important aspect of managing, of coming through a pandemic. The next one ethical issue that I like to highlight is the dilemmas that we face confronting the workforce, the healthcare workforce contend with. And you're all aware of this, and one of the most pressing dilemmas have emerged at this point have been the shortage of essential resources, EPP, and some similar for frontline clinicians. And due to the shortage of resources, ventilators, we have the extremely difficult situation of having to make decisions about which patient will or won't have priority claim on the limited supply of ventilators. and other even medicines and treatments. And then from another perspective, we see that so morals philosophers and so forth are able to tell you that you're not under ethical obligation to treat patients if you are at a risk of your own well-being. That's from a philosophical, ethical perspective, but from our perspective as a healthcare provider, and again confirmed by the WMA, we don't have that option because you chose to become a doctor or a healthcare nurse, knowing well that that was what you were going to do. Just as someone joins the army, a soldier joins the army knowing that he or she has to go to war. So that covers that area. But I don't need to go through all this because you all know that the figures are going higher and higher. And looking at the number of doctors, nurses, healthcare workers who have been infected, died, and if in fact if infected their families and so forth around the world. And even as far as March, in the Los Angeles Times, there is an article about India where doctors were are being infected, trolled, and even being evicted of their houses. The national health system has been that. Australia, even right now, is having the same problem, and they've called in the Army Medical Corps to replace some of the issues that's happening in Melbourne, where the workforce, the medical and healthcare workforce have gone on well. So we find dilemmas that we've had to deal with. Our nurses and doctors obliged to help when they're going to risk their own life, their health and life. What are the consequences can be drawn from shortage of essential equipment? And again, in countries like United Kingdom, Australia, USA, and so forth, they have been calling for retired health because of the surge. To manage the surge, they've asked for retired healthcare people to come back and help. So how ethical is that, asking the vulnerable group of retired healthcare providers to come back to take a frontline place in this pandemic? Now that's the type of things we have. And I will have one more, and this is the issue about the ethical issue and the dilemma that we face, even in such a thing as reopening the economy. And India is going through that, United Kingdom, we've got this in Australia. What do? We have two, economic well-being or population health. So do we open up, kickstart the economy because we want to improve jobs, economy, and financial, economic well-being? But we know that brings on the risk of spreading the virus. That means strain on the health system, hospital beds, but importantly, mortality and morbidity. But we have to choose between these two. If we remain locked down or quarantined, we close business and schools, health system and the hospital might have less of a strain, and they might be able to continue to provide better healthcare. But then we risk job loss, recession, poverty, and economic well-being is impacted. So we have this choice, and you can see United States, they are arguing, states have decided against the doctor's advice, and opened up. And we have seen the surge in cases and so forth. The same has happened in India in some places. In Australia, we have this issue where we have one state opened up, another state not yet opened, frightened, and then that leads to issues of blockade, closing of borders, because so this whole issue becomes so complicated. And I think those areas. So there are several more areas, but I wanted to highlight these very important areas that I've highlighted. Now, from these dilemmas to a post-COVID bioethics, what do we learn at the end of the suffering, the end of the hardship? Can we make a difference? How can we ensure that marginalized populations can access the care they need? How should we balance our need for surveillance when we consider with consideration of one's privacy? What ethical duties do we owe to vulnerable people, particularly those separated from their families and communities? And how do we ethically and legally balance public health and civil liberties when we're keeping people confined to prevent the infection? Those are some of the questions that we like to take up. Now, these are questions, and these type of questions are not uncommon because, but this time we need to answer these rather urgently, but from a global perspective and to have some concrete settings, because this has created unprecedented circumstances. So, re-looking at all this, can we consider, I'm asking all of you to consider, is this an opportunity for bioethics to learn all those lessons that I've just brought out, I tried to bring out to you? And if that is so, what should the post-COVID bioethics look like or be perceived like? Something to think about, something to think and then make it reality. Little bit to know that the bioethics, birth and progression, was from the 50s and 60s as a reaction to the atrocities of World War II, when we saw violation of human rights in medical research and so forth, and the Nuremberg and the Helsinki Declaration and all came in there. So historically, bioethics has focused a lot on combating medical paternalism and protecting and promoting individual rights, particularly in the Western context. And what has that resulted in? 30, 50 years of focusing on this. We have very impressive work on personal autonomy, rights of the patient, rights of the research participants to choose how they want to be treated, and informed consent has become central to all interventions and so forth. But let's look at what we haven't been so effective. Less focused areas. We do see from what we've experienced now, certainly we haven't focused. We didn't have a big focus on the issues of policy and framework related to justice, but importantly, distributive justice. That's one important aspect. The second issue that we see from what we've experienced is coping with bioethical issues related to families and cultural communities. And of course, even the tools for public health ethics was only more recently developed. So, one of the things that we learn from this is there's we need an emphasis on connectedness and a global response, because the virus threatens all of us, all over the world. I'm here in Australia, no different, sitting in a lockdown, having the same issues that you're having there, and someone in Africa is having the same issues, or in Latin America. And what we also learn from our experience, is that the actions of each of us have an immediate and dramatic impact on others. Having learned all this, can the legacy of COVID for bioethics be a dramatic shift towards the areas that I've just shown you that we now learn needs growing recognition and indeed implementation. And for that, I looked and I thought of three important areas that we might think about, that we think that might be take an important place in the post-COVID bioethics and in preparation for the next pandemic or epidemic. The importance of emphasis on distributive justice. I've been showing you how difficult it was when you didn't have enough resources. You had to allocate the resource allocation. How do we do it? Of course, this resource developing tools to have this done in a fair manner. And this is, of course, it shouldn't happen only in a pandemic, but much more broadly. And of course, we learned from this pandemic that resources are limited, and this is going to be always true. And we know that all the resources in the world cannot meet the healthcare needs of all the citizens. So what happens when that type of a situation is there? Allocation is done implicitly, right? But the post-COVID bioethics, maybe we should show a moral courage in making this allocation or this aspects of healthcare, that is scarce resources being allocated, having an explicit method or policy to have this allocation done. And that should be based on the foundation of transparency to justify allocation decisions, which will ensure that three important aspects will be there. It is equitable, coherent, and transparent. So that's the first one. And the second one that I thought was important would be the very healthcare. And of course, bioethics should be applied to a broader context in which healthcare is embedded. What we learned that promoting the understanding that ethical challenges related to health are always present, and it's not only in the pandemic that this happens or when medical attention is required. And importantly, that we learn now, healthcare outcomes depend on socio-economic status. From this pandemic, we are able to see very clearly that, and the ways in which families and communities are embedded in the health system. So another issue in a post-COVID bioethics should understand, importantly, people as embedded in the social and cultural network, and so should be taking that into consideration in the future. And the third and last issue is about global aspects of this bioethical dilemmas. What we see from exploring the global aspects of this, that post-COVID bioethics should recognize one important issue here is connectedness. And this connectedness is not just as members of your local society or local city, but indeed as members of a global community. Then it means when we take it into that level of a global community, then we begin to appreciate that each one of us owe across the border, not just within our borders, but we owe each other across the borders. And how we understand how a local decision impacts other regions. And when that happens, it appears to happen to the most disadvantaged ones are the ones to be affected. So bioethical thinking about resource allocation and priority setting had in the past neglected a global perspective, and the post-global or post-COVID bioethics should make a change so that we have a global perspective when it comes to resource allocation priority. And you can see this issue already coming up with the vaccine. We know that United States has already bought up the vaccine that is not yet produced, millions. United Kingdom has bought up already millions. So these are some of the things that we are learning. And I think the post-COVID bioethics will need to take these areas. So in conclusion, coming in from the pandemic, from a history that emphasized individual autonomy in a local context, I think a post-COVID bioethics should embrace the challenges that we've seen that were raised by justice in that distributive justice, but in a global context. The post-COVID bioethics should also have an emphasis on fairness, transparency, trust, solidarity, and compassion as leading values. If we could have this as the post-COVID bioethics, then we could have a positive legacy of the most challenging and difficult period that the world has and continues facing and trying to respond to this pandemic. Thank you very much.
Thank you so much for the very detailed and multifaceted perspective on situation of around bioethics during the pandemic, and also a lot of food for thought on maybe how it should be going further. And I think there's not anything I can think of that you have left untouched. Thank you so much for that presentation, sir. Now, that brings us to the next presentation, which is going to be delivered by Dr. Mary Matthew. The introduction, the bio is very long, but I'll keep it as short as I can. Dr. Mary Matthew is a professor of pathology at Kasturba Medical College, Manipal, Karnataka. She's also the coordinator for Center of Fetal and Perinatal Pathology. She is currently the head of the Indian programs of the International Network of UNESCO Chair in Bioethics. She is also an International Council member of the Department of Education at the International Network of UNESCO Chair in Bioethics, Haifa. She has been an undergraduate MBBS teacher for 26 years. And it's with a lot of pride that I can say she's also my professor, and has been the inspiration for me to begin working or inclining towards bioethics, and that is how I started here. She's over 100 publications in pathology and also bioethics, and has been a guide for hundreds of students in her professional career. With that short introduction, I'd like to give the floor to Dr. Mary.
Thank you, Purva Prabha, and thank you, MSCI, for inviting me to give this talk. I'll keep my talk short and simple, and just to tell you that I'll be talking about medical education in the time of COVID-19 pandemic. I'm sure we'll have a lot of I'm hoping at least we can have a lot of discussion, because I'm going to tell you what are the challenges that we are facing as teachers, and what are the challenges that students have during this, medical students, when I say students, I mean medical students, have during this pandemic. So I'll just share my slide. Yeah. Okay, so once again, I also like to thank my mentor, Dr. Russell D'Souza, for he's been my mentor when it comes to bioethics, and he's a very, as all of you know, as students and faculty, that he's been a very encouraging person, not only for the faculty, but also students. He loves to interact with them, loves to take the cause of bioethics forward, because I think we are living in times where ethics is becoming very important, not only in our curriculum, but also as a way of life. So today I will start with the challenges that has been posed due to this COVID-19 pandemic. Now, what has happened in medical education is because of this, we are forced to socially distance. And as of today, I understand that we're not going to call it social distancing anymore, and it is actually physical distancing. And that should be the correct word to use, because we are not actually socially distancing, we are physically distancing from each other. Now, because of this physical distance, there is a reduced face-to-face teaching. And all of a sudden, everyone had to transition to online platforms to deliver the curricula. We were not very comfortable. We actually prided ourselves in taking lectures, and we were not really prepared for to teach on an online platform. And the next thing they said that we have to finish our portions after the lockdown was over. We have to finish our portions within the stipulated time, as well as conduct assessment and exams and monitor students' progress. Now, this is very challenging for a teacher to sit on the other side and not have any contact with the student. One of the most difficult problems that we are facing, at least in the clinical side, is assessment of clinical teaching and soft skills for the students. This has proved to be very, very difficult. And of course, we also concerned about our students' well-being. We really don't know where they are and what they're doing and how they're doing. So I have divided into two, that is challenges faced by the teacher and challenges faced by the students. I would love to know what challenges all of you have had as students. For us as teachers, we had to deliver high quality education using online platforms. By itself, if you look at the senior teachers, we are not comfortable with technology. And not everyone is computer savvy. However, the junior faculty they were very innovative and very happy, in fact, to use technology as a medium to conduct lessons or classes. But what was happening on the other side of the screen, we really didn't know, because we had actually minimal or no input from the students. When you take class online, you don't know what is happening on the other side. And it was very difficult to keep track of the students. And keeping track was okay, but we did have naughty students are naughty, not only face-to-face, but also on online. So we did have challenges of, students capturing our, I don't know if the correct word is confiscating our lectures and taking control over our lectures. So we had to deal with issues like this when we started taking classes. But of course, with time, we have modified and we have learned to use the online platform. We also had to use different teaching technologies. And for some of the faculty, it was really a joy to use technology and different modalities of teaching. But what was missing was actually the loss of social interaction. We've also had a lot of problems regarding how to assess students when we don't see them face to face. And online assessment is it really correct to do just online assessment? For the students, not everyone is, even though I'm sure you can say 99% of students are used to technology, there are students who are not used to technology. Manipal being a private institution, our students are very privileged. They know they have access to technology, but over the time when we've been conducting these UNESCO programs, we've had teachers from the government colleges saying that our students are stuck somewhere and they had gone home for holidays, and then they didn't come back because of this lockdown. And now they're having issues regarding connectivity, and some have no access. They don't even have a computer at home. So these were the problems that the students faced. Another problem was sitting in long hours in front of the computer. You and I know, unless it's a movie, we don't sit through anything for 3 hours or 1 hour or 1.5 hours, especially when it is a class. And that itself had health issues. Students, everyone can be, we all are very easily distracted because our attention span is quite short when it comes to learning something. And even monitoring was very difficult. And there is this expression that they use self-regulated learning. Unless you're a student who is used to self-regulated learning, you have the discipline, this online platform becomes very difficult. Because the classes just go online, and if you don't keep up with the classes, then it becomes difficult over time. So what were the solutions that, at least I'm talking from the perspective here in Manipal, what happened when we first heard that we were told to take everything, all classes online. They ensured that we had access to internet. And of course, there were little issues, teething problems in the beginning. But one thing good about our institution was they ensured that there was a faculty development program. So all of us had to go online, and it was not only medical, of course, engineering, all the faculty here in our university we were taught how to create an online discussion room, how to handle Microsoft Teams, which we use for as a platform to teach, to record a lecture, how to keep track of students, and the various other ways, modalities of teaching. And one thing we understood was, compared to the usual summative assessment, formative assessment was very easy, because you can just give a MCQ at the end of your class and see if actually the students are learning. So that was one of the easier parts of teaching. Many other staff or our faculty have used social media, video conferencing, podcasts, a lot of ways of teaching their subject. For some, it was really a joy, especially those who love technology. It was really a joy to teach on using the online platform. The Medical Council of India has been telling for a long time that we have to eliminate, or rather reduce, lectures and go on to this technology platform to replace and to enhance learning. And COVID-19 has given that opportunity for us to transition to online platforms in a very fast way. So even those who were reluctant to go online were forced to go online and take classes. And we realized that we are able to facilitate learning through bringing teams together. And you can also enhance active and self-directed learning through this technology platform. Right now, all our meetings are now online when it comes to something what we call a tumor board, where we discuss a patient from all disciplines. All disciplines are involved in the treatment of a patient. So you have a platform, a central platform where the pathologist comes in, the surgeon comes in, the radiologist come in, the oncology surgeons come in, medical oncology comes in. All of us come together on an online platform to look after this particular patient. And it has helped us a lot, because now we don't need to walk to a particular point in the hospital for a meeting, and we can just go online and discuss everything, including the radiology, which we can see. So another thing that we've learned is that we can also use, it can enhance interprofessional learning, that is between professions. So if you just want another profession into the education, you can always invite them and ask them to be part of this. So when it comes to student, the solutions, pre and paraclinical subjects, we actually didn't have much of a problem, because we could use anything from videotape vignettes to even videos and mannequins to show, because they're time tested. These were all used as patient surrogates. Or in anatomy, they online labeled images. This time in pathology, we had a postgraduate exam. We conducted what is called as using specimen pots. That is, you just the first day of examination for a pathologist, pathology postgraduate, is actually they have to conduct an autopsy. So that was not possible because of the COVID-19 pandemic. And so what we did is we constructed an autopsy. So we got all the organs together to simulate a particular disease, and it is what we call as a constructed autopsy. So when difficult times, when challenges come, when you're forced to forced to make decisions, you do come up with innovative solutions to solve a problem. We've used with this, online platforms are good for flipped classrooms. You can use recorded lecture, live streams, you can have interactive learning, even in fact, you can form even group-based learning. So this is okay as long as we are in the pre and paraclinical side. And even certain universities have used telehealth so that the interns can be in touch with their consultants if there is a telehealth platform. And telehealth platform has been shown to improve interpersonal skills of a student. But the problem comes here, patient contact-based teaching. We all know much of the learning, much of our medical school learning came from the ward rounds and clinics and theaters. Now this is where students have really lost out, because many medical schools have forbidden patient interaction for their students for fear of litigation, especially in the Western countries. But in countries such as UK, students have been recruited as frontline clinicians. That is, at least if they cannot provide clinical service, they can be there for if required for the laboratory investigations or for screening patients. But and especially this would help in places where there is a shortage of workforce. I know that in Mumbai, a lot of students have been called to come in as frontline workers, and that is not by choice, but they're forced to come in, and that I think is very unethical. And we understand that a letter was forwarded from the Gujarat health minister saying that all students from Gujarat are supposed to come in and help, and they've given some sort of remuneration. But that is a view which may differ among people and among students. But whatever it is, we have to ensure that our students know how to use up the personal protective equipment. Many of the medical colleges do not have personal protective equipment, and students are faced to just are forced rather to go and just go into the front lines just wearing a mask and hardly any protective equipment, which I think is very wrong. At least the basics of the health students, health of the students should be looked into, and they should be taught what they are using now, what is called as SMS, that is sanitizing, masking, and social distancing. So that is very important. If you're sending a student in the front line, it is important that we also take care of them. And something that has suffered a lot is mentoring of students. Now, mentoring of students, we know that many students who are very anxious, some are depressed, they don't know what is happening, about what will happen to the future, because this looks like a pandemic that is not going to stop anytime, in the near future. It won't probably, we are thinking in terms of next year. So what happens, student and helplines for the students should be open, and mentoring cells should be open, especially for students who require those needs and who require supervision. In assessment was where we had theory examination to conduct. Was not actually difficult for us, because there are many softwares to conduct theory exams. Abroad, they are now practicing open book examination, and they say that at least will reduce the stress and the anxiety of a student. But of course, in India, we still haven't started this pattern of examination. Practical examination is where we have problems. How do we assess verbal and non-verbal skills? How do we assess clinical examination and reasoning? And like I said, in pathology, we were able to do the constructed autopsy and simulated exercises. So we didn't have really much of a problem. But conducting an exam in the clinical setting will probably be is a challenge. Now, there is a good article which was written from the University of Singapore with the Duke University as to how to conduct a high-stake OSCE, that is clinical examination in a COVID-19 environment. And they have in detail explained and shown how to conduct a clinical exam for medical students during this pandemic, and the measurement, the distance, how far a patient should be, how far the doctor should be, everything was prescribed in that article. So this is to tell you, this is the picture of our dental department, where have successfully conducted the postgraduate exam. So it is not impossible, it is possible, especially if there are resources and means to do it, it is possible to conduct the exam. But I know that in government colleges, it may not be as possible. And we must now actually think of virtual patients, because time has come that, this we may run into shortage of patients. We may run in situations such as how we are now, that is a pandemic. So a virtual patient would be the future, where students can go and learn and also be examined through this virtual patients. Now, the last I want to talk to you about is research, which Dr. Princey, our next speaker, will be taking on, is about research. Now, if many of you, I'm sure, would have noticed that now the research is only on COVID-19. Millions of dollars have been poured into this COVID-19 research at the cost of some other research. So what was ongoing and what was essential, actually right now there are hardly any funds for research in other fields. And this is a nice paper which is put out by Dr. Madhukar Pai, and he's from Canada, from the McGill University, and he said, COVIDization of research, what are the risks? And he said, in this article, he was talking about how now papers are just overflowing about COVID-19 research. And many of them were dubious, and many cases, I'm sure you've heard, that the research had to be retracted because of lowering of the normal scientific norms and standards. And what happens when you have multiple papers coming, different people doing different researches and trying to prove and then retract the paper saying the study was not done properly? It leads to bad science. And this combined with poor science communication, what happens? This goes out into the public domain, and the public has less no faith in the medical doctors and their research. And because this research is so haphazard and there is no, scientific standards are not maintained, policymakers also can't take a decision. I'm sure you've heard about the hydroxychloroquine fiasco. I must tell you now, there are about 150 trials which are registered just based on this hydroxychloroquine. And many trials have been discontinued, or the researchers are having problems enrolling patients. Now, what happens to such kind of studies? While so much of funds and time wastage on just one drug, which is not being studied properly. So now we are at a stage where, is hydroxychloroquine good or is it bad? Should we take it? Should we not take it? So that is a situation we are faced with right now. Yeah, so it is really a big risk when a pandemic like this happens. If you remember the Zika virus outbreak and the Ebola outbreak, during that time, a lot of money went in for the Zika and Ebola. Now you don't hear it anymore. Whatever product was formed during that time has disappeared from the market. And when there was an outbreak of Ebola in 2018, again, there was nothing for them to fall back on, because the products or whatever treatment or vaccine or whatever they were trying for didn't succeed or was not available. So it's not very easy to sustain such crisis-driven initiatives. And there is a term which Dr. Madhukar Pai used. It's called epistemic trespassing. That is, you are a researcher with a particular experience, and at this time, everything is about COVID-19. The research is about COVID-19. So from your field, you jump into COVID-19, where you hardly have much knowledge, and you pass a judgment. And this leads to a lot of, this is very dangerous, because the outcome is not good. And researches which are important, like non-communicable diseases, which are the leading killers now in low-income countries, they are not being funded. And even research on climate change, all that has stopped just because now all the funds is being poured into COVID-19. So he says, this is a statement that Dr. Madhukar Pai says. He says, as a scientific community, we need to acknowledge that all health research cannot be about pandemic or infectious threats, and all infectious disease research cannot be about COVID-19. Therefore, governments, funders, universities, journals, and individual researchers should be thoughtful about the risk of COVIDization and should not forget that diversity in research is critical for any society, right? So we have to be careful about how the funds are spent at during pandemic, and is it really worth putting in billions and millions of dollars into one particular disease? So with that, thank you, and you can. I will take questions whenever Purva says we can. If you want to ask, I'll be happy to answer. So thank you very much.
Thank you so much, ma'am. We can take questions at the end of the webinar after Dr. Prati is also done with the intervention. Your talk has been an eye-opener for us to see the other side of the aisle, because I think we were just cribbing and frankly complaining about the problems we have and didn't quite honestly look at it from the teacher's side, and also from the research perspective. It's only now that I actually started thinking in directions of, okay, wow, we've cut funding for a lot of things. So thank you so much for that, ma'am. With that, we move on to the last presentation for today, which is indeed an interesting topic also, in terms of just how much news we're seeing around clinical trials and a new vaccine coming up. So the last presenter for today is Professor Dr. Princey, who is currently affiliated with the Amrita Institute of Medical Sciences and Research, and is the head of the Bioethics curriculum of the Indian program of the UNESCO chair. So, ma'am, I hand the floor over to you.
Myself, thank you. Thank you. I am myself Dr. Rosmi David, PG resident of Amrita Institute. Good afternoon, and dear dignitaries. Sorry for the inconvenience. Ma'am is currently inaugurating one webinar on medication safety here. So she will be expected to join within 5 minutes. So I would like to share the slides of her. Meanwhile, she will join.
Dr. Purva, maybe we can take questions while Dr. Princey comes back. Is that okay? Because
yes, I think that would be
better. So I think Dr. Rosmi, we will wait for Dr. Princey. In the meantime, we'll take questions. Is that okay?
Okay, ma'am. Sure, ma'am. I will tell her, ma'am.
Yeah,
okay, sure, ma'am.
We have a few messages in the chat box from people who responded to your call on finding what problems students are having. And we have a participant of ours, Manya, has mentioned lack of attention and interest from time to time, not being able to understand as much as she would in a clinical teaching setting. Loss of a routine, discipline and motivation, and also no accountability, which I 100% also agree on. And it's easy for the mind to stray.
Yes,
lack of
that is for all of us. That is for all of us. Yeah.
Yes. So we have a question on how would you suggest staying motivated for students?
How do you be motivated for? So I was taking actually one of our, because we are affiliated to the Malacca program, the Malaysian program, and we had to take this online classes because they are actually in Malaysia right now. They haven't come back, so they were not able to come back. So we took classes for them online. And my last slide was stay safe, stay positive. And one of the students said, "Madam, how do you stay positive?" And I think that is the problem when what I did say was you have to focus on something very far. That is, you have to focus on seeing yourself as a doctor now. so that you work towards that in a positive attitude will keep you safe and keep you towards that goal. So you aim for something that you don't have right now and work towards it. That probably should be some sort of ambition to keep you to guide you and to keep you keep your presence of mind. But I think the question was what was the question, Purva? What was it?
The question was, how do students stay motivated? We have a few more, but I think this is asked by 3 people so
Yeah,
far.
how do you stay motivated? Yeah, no, you have to, because one thing you should remember, you should be the motivator for someone else, especially your family, because as a doctor, as your profession calls you to be a motivator, so you have to stay positive. So only by when you motivate someone, when you you kind of experience uh, experience it both ways. You're motivating yourself as well as you're motivating someone else. But I'm sure Dr. Russell is there, or he's just I think he's not there. Probably he's gone to the same. But we don't have a choice. We I don't know, there's a verse that says, think of what is beautiful, what is kind, what is good. And that is how stay positive. I'd say positive, be more positive, and that can lead to, if you are a motivator that yourself, you'll be motivating yourself. So I don't know, because I'm very positive. I have, and another thing which I have realized is what is making me stay positive, that whatever extracurricular activities that I've always longed to do, especially, things like art and painting and gardening and crocheting. These were things which I never had time before the COVID-19 pandemic. And I have taken that all up again. And I'm finding joy in that. So I'm sure, when you take up some other activity rather than focusing on your studies yourself, you will realize that there's something more to this than just it is not really studying. I can see that Manya Sharawat has written, I'm a first year student and I've been facing so much of anxiety, uncertainty since we are given orders to report to our college and study offline with any SOPs. Okay. There's still uncertainty because of MCI failing to pass orders on time. Yes, this is actually, this uncertainty of the pandemic is what is making us all very, which is actually demotivating us. Because there are people, especially for our postgraduates in pathology, they were not sure. They were supposed to write the exams in April. Then they were not sure they're going to write in May. Then they were not sure, when they. So this is actually, it's very discouraging, and it's very difficult at this point to be motivated. But my suggestion would be never to isolate yourself. That you should talk to people. You should talk to your friends, talk to family, and never internalize all this, because I can see that a lot of you are very anxious. So never internalize your fears. You should always talk it out with someone. And if you have a helpline or if you have a mentor cell, please reach out and speak to someone who can, advise you and help you during this crisis. I think Dr. Princey is back. Princey?
Yes.
You're
I'm
back.
here.
All right. Okay.
Am I audible?
Yeah. I think, yeah, you are.
Yeah. And my slides are visible?
Yeah.
Is the slide visible? Right.
Yes, ma'am.
So thank you all for having given me this great opportunity to come to students, which is who are one of the reasons why we are for. So it's 50% for the students and rest for the patients and the rest of the world. So students are important. So here we go into the ethics of clinical trials in the COVID era. Friends, I would just like you to think, when we know that there is a disease and the disease has a cure, whatever the disease, I got something, but if you know that you have a cure for it, or there is a drug for it, there is a medicine for it, it's okay. You can take it. And as Dr. Mary was just telling about the uncertainty, that is what that suspense, that is what is at the whole. I mean, corona is not a disease that is so, the death rate is very low as you compare it with other other infections. But this is something that is spreading fast, and that is one of the aspects that is important. But the most important is that we are not aware. We are not knowing who the enemy is. Next slide. Just press it. Yeah. I have a, why is the slide not changing? Oh. Slide. One second. Yeah. Yes. I don't know why the slide is not changing. Are the slides visible?
No, ma'am. I think you'll have
No,
to
your
reshare.
slides are not visible, Princey.
Okay. We
Share,
have to.
share your slide.
Yes.
Share.
One second. Oh. Then keep it like this. Don't change it. Yeah. We'll go on. Is it visible now, the slides?
No, not yet.
Not yet.
Right, it's come now.
It is visible now.
It's come now.
Yeah.
Okay.
Princey, make it, expand it. Go to the full.
A slideshow, when I had put, it was not visible.
Is it? In slideshow,
Yeah.
if you go the full
I
one.
had put it on slideshow and then it came not visible. Should we try once more?
You just try, because I can see it here.
Yes, sir. One sec. I'll just try it again.
Just see if it's part. If not, don't worry.
See it? Put on full show?
Yeah, that's what I was telling you to do.
Yeah. Let's give it. I've tried to put it on slideshow and the screen is just low. I don't know why it did so long.
All right, then I think this doesn't matter. You'll have to, can you move the slides when you have it like that?
Yeah, I will do that. I will do that.
Okay.
Okay. Is it visible now?
Yeah. This is okay now.
Okay. Now it's like.
I think it's the background. That's why it's.
Okay. Just taking time to change, I think.
Is it changing?
It's going round. The computer is working. Why don't we take it the previous way? Then I can.
What you can do is probably you can read out of it also, if that is possible.
Fine.
So,
the other way it was coming, but not to the slide.
Okay. Then go back. Then doesn't matter. Go back to the other way where it's not full show.
Yes, I'll go back.
And just read out of it. Yeah.
Right. Yeah. No, go back the other way. It is taking too much time. Yeah. Are the slides visible?
No.
Yeah, one sec. I'm sharing.
Yeah. Yeah, now it's visible.
Yes, sir. That's fine, sir. I'll keep it this way and I'll go forward. I don't want to take more time from others. Yeah. So as we said, when the disease has a cure and a drug for it, we are cool with it. So what happens when it is COVID? The problem is we have to learn from our prior knowledge, because we have seen such viruses. 1920s, we had the Spanish flu, and we've got a lot of lessons to learn from. In fact, we have a prior knowledge from which we can take a jump start, and that has helped us a bit this time round. And also the SARS and the MERS has also helped us in understanding and coming to a quicker response when compared with COVID. So as we see, we are talking about drugs have to come on when there is a new disease on the block. When there's a new disease on the block, we have to get drugs expedited. Reviews can be done as it is given in the ICMR booklet, where the ethical guidelines are given in October 2017, that we can do expedited review in times of when there is a disaster waiting to happen, there is a disaster, and such times we can take an expedited review. You could give a rough protocol, inform the IEC, and go further with the program. So that is how we have expedited review, and this allows for the drug to be coming through the clinical phases at a quicker. There's another thing that is called as the Emergency Use Authorization, EUA. When you talk about EUA, Emergency Use Authorization, that is a term that is allowed remdesivir, which would take so many years through the clinical trials. It has been fast forwarded and allowed for use. So although there is some amount of efficacy and safety seen in the small numbers that it has been tried in normal drug approval does not occur with a short period of time. But because of the need for the lack of any other drug as a remedy, there is the option of emergency use authorization, EUA. And so we have got all the drugs that can come through this, and remdesivir, febinavir, these are the drugs that have come through in this, docilizumab. These are drugs that have come through the EUA as a recourse, as a remedy for COVID-19. So that is one aspect. Now, you have heard about human challenge trials. What are human challenge trials? You're exposing the people to the virus, to the uncontrolled virus. Is that right? It is morally absolutely not approved. Moral approval is not there for such a trial, but we have heard of people, this human challenge trials are acceptable because it has a formidable presumption that it can increase and speed up the vaccine trials, so it can speed up the coming of the vaccines. And this is a formidable presumption upon which we can call it as an advantage for the human challenges. But morally, it is absolutely not the done thing. So when we have drug trials, the drugs have to first get through the new entity molecules, innovator molecules. It goes in through the potential seen in the animal studies. And then before it is ready and approved that it is really effective in animal studies, we have to do preclinical toxicity studies before it can come for a clinical trial. So that's how we are standing. Some drugs are at this level. Many of them are already in the phases of phase 1, phase 2, phase 3 trials. So if you see, we have our vaccine trials also in phase 3, many of the vaccine trials. Okay, so now drug trials is one aspect, and another different aspect you could consider for the vaccine trials. The phases of clinical trials are the same, but I would take us a little caution into telling what is vaccine trials. In vaccine trials, you can use vaccines, as you know your immunology you have studied. The vaccines can be taken from the mRNA, from the outermost coat, where there are the antigens that are specific to it. You could call them spikes, through which you can develop a vaccine that's a component, or you could also have for the lipoprotein envelope, the nucleocapsid cover. So you can have for these components too. So vaccine trials are on now, and you can have live attenuated or killed vaccines, as we have known about. So here we have the Indian, we have the COVAX vaccine, we have the Oxford vaccine that is coming through called as CHAD OX1 COVID-19. So all these vaccines are waiting to come out, and every country, in fact, this is what I have come to realize, that the governments are proposing the taking the backing for these vaccine trials. So you see an element of um, this is called as conflict of interest, if you would talk in ethical terms. So here comes the aspect of economic viability of a country, and that comes with vaccine trials. And as you know, we have passed through lockdowns, and we have gone through the next wave of lockdowns, and we have seen a spiking of the cases, and we have gone through so many matters. We have lost out what we were naturally and routinely doing. In fact, I believe students are waiting to get back to their schools, which is unheard of. But yes, get back into the routine. You're missing that naturality. So all these things put in, there is a stress, there is a duress for the drugs and for the vaccine trials to be pushed through, and it should come out. So it cannot be just in the pipeline, it has to come out at the shortest and the earliest period. So what are the things? I have just jotted a few of the aspects. So we have to see the clinical and the social and the clinical value of this clinical trial that can allow for it to happen. You have to see the specific validity also that needs to occur. So not only, so it's a social need, it's a necessity of the world. So whoever brings out the drug, you have a monopoly, and there is so many other aspects, not only about curing, if in efficacy is not proved. So what happens, even if you had a drug trial, a vaccine trial should take at least 9 months to see the efficacy and safety. With a short trial, you're compromising on the safety, which would not be seen in a short time. The adverse effect would be seen a lot later, and we are putting the drug back out in the market. So we are compromising ourselves on the safety. And efficacy is another big question. To some extent, it is efficacious, but you have to do the proper drawn out study and not a short one. But when we have no other recurse, we can take the license to get these drugs out a little earlier. Then we see all these other factors. You are aware of informed consent. We are aware of all these other aspects, but I would like to talk to you about the potential and uh, uh, the patients who are going to be committed. The recruitment of the patients in this study. And anybody who is in the study, we are talking about the term, bioethical term called vulnerability. If I'm supposed to have, if I'm suffering from COVID and I'm COVID positive, I would grab at any straw that would give me, it may be I may recover in by itself, or I would grab at any straw. So there again, are we taking the informed consent process is occurring, but is it without duress? Is there some sort of a pressure upon the patient and the people conducting? So all these points. These are the few of the points that are highly relevant in the COVID era. And if you see the number of drugs that has been destined and used very rarely, it is varying from anti-inflammatory drugs. It is varying from colchicine, febuxostat, a gout, anti-gout drug, and so many, and diverse group of drugs. Ivermectin, hydroxychloroquine, again for its anti-inflammatory action. So that's how we have come through. Hydroxychloroquine, in the time of Spanish flu, it was used rampantly and did give relief. But what happened was they couldn't keep up the supply. And so they started having cinchona plantations everywhere. So that was one of the, and that was a better option. So that, those are some things we learned from the century ago. So here we have some of the aspects. Next slide. And I would just like to, before I end, I didn't keep much slides. I would like to tell about the human recruitment, the subject recruitment, and who makes the recruitment, how it is done, with or without duress. That is a point that has to be noted, because when you talk about the specific validity, the validity of the clinical trial is lost when you take, you are not taking the randomized, and we are not taking the proper group of patients. Now, if you see, the Oxfam vaccines has been tried in 10,000 people across UK, Brazil, South Africa, etc. And they are doing good because they are showing good response. And the country that comes out with the one, and they are, it's a race for the first vaccine out, because there we have a real economic benefit. So the question of the whole basic principles of ethics in clinical trials is the clinical equipoise. That should not be unbalanced. So the clinical equipoise should not be unbalanced. Another aspect is all the basic principles that we have. In Dr. Russell's talk, you have heard about, he mentioned transparency. He did mention about stigmatization, discrimination. Yes, all these aspects are also important when you're talking about. And one of uh, 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 the most pricking point in this clinical trials in the COVID era is the aspect of economic validity and the race and the conflict of interest that is happening, use of the subjects. What about placebo control? What about parallel and non-parallel studies? These are the issues that the researchers and scientists are talking about to bring out the right drug and serve it as the remedy for COVID-19 and ease the uncertainty and the suspense, and let us get back to normalcy. Thank you all. I'm ready to take any questions. I know I have not done a great job because there is a lot that needs to be talked about this. Thank you.
Thank you so much for your presentation, ma'am. I'm not sure why you feel you haven't done a great job, because you've added too much perspective to our initial raw thoughts around clinical trials, around the race to get a vaccine, so on and so forth. We have a few minutes to take questions. So we already have some questions in the chat box. And if there are more, I'm requesting the participants to add it to the chat box or raise their hands if they want to unmute and ask any questions. I think the first one I can already ask any of our three panelists to answer is the ethical point of view in calling upon final year medical students to COVID duties, as it's being done in a few states already. And there's an additional question to that in terms of people who have been called for duties. Are there any tips or advices from your end on how to handle the stress of these duties, or any other advice that you would want to give?
Dr. Russell, how do you They want to know how are they supposed to handle stress of duty and studies? They're
Sorry.
called to do both.
Students.
Well, we had this, you are talking about students are being given work to work with COVID, is it?
Yeah.
Yeah, that again, this is an issue that every country seems to be. In US, they're not allowed at all. In UK, they can join, but they don't do clinical work, but they work in other roles. And in Italy and some other places, they pushed you through and put you in the first step. So this was the issue that we looked at. It is not ethical that a student should be put into that situation both ways. They're not yet ready. And the other thing is that there is the issue of safety and all that. Is it regular? Now, are you talking about anxiety? Because I didn't put that in. That was one of the other issues. The issues about psychological health and the dilemmas that we face. And we have three. You got one issue is about people who already have a problem, an illness getting worse. You get the effect of media and all this causing. And then the third important area is the psychological effect on the healthcare workforce. This has become a very big issue around the world, and that seems to be a need. So your students will come in that within that domain. That either they even if they were pretty much had no problems, there is evidence of just the whole pandemic bringing on anxiety and even traumatic issues and so forth.
That's what I was telling Dr. Russell, that there should be a mentoring cell and a helpline which should be in place, so that when students need anything, that they should a support system more than that. Support system yes. should be in place. Because but I'm sure in many colleges it's not, especially the government colleges, it may not be available. So they are actually asking how to be resilient and how to survive this crisis, as well as, because the fear, they're very anxious and they're very scared that, they will get
yes.
infection.
I think there are two aspects. One is resilience prevention, and the other is being able to have a lot of anxiety comes when you don't even have a resource to go to.
Yeah.
You see, if I've got a problem and with the exams one side, there's a lot of uncertainty about your exams, about playing all these. There is already a heightened anxiety already there, and then when you have these other facts, this becomes certainly it's this is an issue. And I think Dr. Mary's suggestion that I'm sure your KMC, you must be having.
We have a support system.
What about Amrita?
Yes, we have a support system.
Most of private colleges have. It is the government colleges who,
I would like to talk about the state of Kerala. In Kerala, we have the social workers. They are online. There is a helpline for all college students, not only our medical colleges. By NABH, we have to keep a medical counselor, but as such, the state has got its own helplines available for not only college students, any
everyone,
youngsters, and they are doing
yes. But I think, Princey, if we had something for medical students, that will be a good thing, because they would rather be to have I know that most places they would have a social work, but usually here they'll have a counselor or a psychologist.
Yes.
From your department of psychology itself, they would give them some duties, isn't it?
No, but are there any other ways, like other than the psychologists and this thing? Is there any way that they can be motivated and stay strong? That would be helpful. Yeah.
The psychologist does that, no? Or for that matter, a counselor. They're going to be giving you exercises, telling you either in a group or in where you have baseline, how maintaining your sleep, all these things, and also using some activities, maybe meditation, yoga, exercises, all those exercises that can help with your cognitive performance, taking in the load. It is hard. Even for me. Yeah, I'm listening to the media all the time. It is it is difficult for even normal people, and then if you've got other stresses of exams, not sure when it's starting, when you want, it becomes very difficult. No?
Yeah, because there is a question in the chat box which says, is it right decision to hold examination in the pandemic situation? See, we can't answer for different institutions take different, they have their own policies. Right or wrong is not the question, but how to.
But taking the exam, isn't that a regulatory requirement? Is it the university or is it the MCA will be deciding that, isn't it, or something?
No, the university decides the exam.
I would just like again to bring a point, because it's been in the news lines. There is an aspect they had, the Kerala state had one entrance exam, and they had inside the schools where the students engineering and architecture, those kind of entrance exams were held in the various schools and colleges. And, they have done it very well for the students, but you would see the swarm of people that came in, parents with the students in the school during the examination. The social distancing, on all those norms are maintained. But, at the entry point, as they come in, it was like a horde, a swarm of people. And as a fallout to that, there were 3 students and 2 of the parents who developed COVID after that session, after that exam. So that has come up in the news, and there is a lot of controversial debates going on about this. But it's a question of your future. So again, no one was asked to, come with the parents, or, they are both sides debates. They say that they should have followed the norms that have been followed. But it is our integrity that our civic sense, that we follow the norms that and guidelines that are given to us, which have not been done at all by the parents who came from out, and they were sitting by the side, in groups
Crowded.
and discussing. Yeah, that's right.
Thank you for those views. Also, some students have been asking on your perspectives around the ethicalities of asking medical students, final year medical students specifically, to even take up compulsory duties.
Yeah, no, that's what we're trying to tell you. It is each university, each institution has decided on certain policies. So we can't comment whether it is right or wrong or ethical, because see, in UK, like Dr. Russell was saying, in UK, the medical students volunteered. Yeah. There were volunteers who came in, so they were happy to volunteer.
Yeah, and they were not given clinical work, but they took on other, triage and this and, other work. That's what they told us. On the other hand, United States, they were completely not allowed to come anywhere near, that type of, and in Europe, some of the places actually, they pushed them through. That means they gave them their qualifications and to
so that they would be recruited as doctors.
But
from all this, we can take a learning. And if we do the things that are needed to be done, I mean, Corona, talking about social distancing, using mask and things, we could have done it. We should be doing things like this. But there is a learning to be taken, and we
Dr. See, I can understand their apprehension, because we're apprehensive now, because they have called our postgraduates, pathology postgraduates, to go into to screen patients. So we are apprehensive about our postgraduates. So I can understand what the students are going through. I don't know, we have a choice. Do we have the right to say no? Unless you have a comorbid condition, you cannot, we don't have a right to say no.
Exactly.
Thank you. I think there's one question specifically addressed to Dr. Princey.
Yes.
It says there's a chance that any potential vaccine for COVID will be patented for financial reasons. What do the guests think about the ethics surrounding that scenario?
No, it's not a chance. It is.
It is coming through.
No, it is that it is, I mean, everyone knows that the first country that gets a vaccine out will make the most money out of it.
Yeah, that was because the thing was on the weekend last week, we had this meeting. They said that the economy is bad in all the places. Everyone said, so this is going to be the
economy booster
for whichever country does this. So all are involved in this, and so every government is also involved in this. And that's why I spoke about in my, in the COVID, post-COVID bioethics, where we have this resource allocation globally. We need to have, because otherwise it will be like, what is that, the antiviral, they bought up
hydroxychloroquine, yeah.
Not hydroxy, the other one.
Remdesivir.
Yes, that's right. US bought up the whole million, and then they gave some to Australia as a token, and it bought the whole thing. So these type of things are there, and the same with the Oxford. It's already
vaccine,
well, it's not even come. God knows whether you'll. There are so many more layers to be done, but I know that UK said they've already taken over 1 million doses, each of them. So what will be left for the others, we'll have to see. So this is going to be the next issue that we'll be dealing with. And this is why we never had this. If you look at ethics, it's always been a lot to do with autonomy, consent, looking after patients, safety, and so forth. But this is the pandemic has brought out.
It's a Pandora's box now. All the unethical issues.
Yeah, but this justice issue has not been a big issue,
so far, now it's come out.
Yeah, because right from who gets the ventilator, who gets the PPE, who gets the vaccine, who gets, each of these things become highly questionable. So it is very important, I think. And I think the post-COVID bioethics will have to look at distributive justice. Okay, very good.
And to close that point about vaccines and drug trials, the ethics should never ever be compromised. And that is why there are ethical guidelines available. But yes, and in a time like this, there is some amount of compromise, but social justice, distributive justice, and the drug to come out, yes, there has to be some.
Yes.
I think, Purva, I have to tell all the participants, I can feel for all of you, because what you've put in the chat box is what they're facing, and we can't give you answers for that, because those are decisions made either by the government or by your own universities. So to comment on that itself would be wrong on our part to say if it is right, ethical or not ethical.
I think there's one very specific question which I'm sure you would love to answer. One of our participants has asked how to take up a career in bioethics after completion of MBBS.
Yeah, I wanted to write on the chat box. Please refer to Dr. Russell D'Souza.
Well, first thing is, before we finish, I can tell you that Purva and your team are going to have the first start for you will be the course that will give you the certificate, which will give you a very beautiful, broad understanding with from an international perspective. So we'll get you, and maybe if you have enough of your MSCI members to take that, particularly now when ethics has come into your curriculum. So it's beyond just, before it was important to do the USMLE and so forth, but now I think it's a requirement, right, for all of you. So let's have that, and if all of you join along, we'll get that going.
I'd like to tell everyone that I'm very happy to announce that both my students who was the president and co-president of the student wing of the UNESCO chair, one has already joined the WHO.
I was just saying,
and the other, that is Dr. Sharan, he was recommended for his residency based on his involvement with the bioethics program. So I think all of you should seriously think about these things, because these are issues which are important, and it'll be good if all of you can participate and take this movement forward. Because at the end of the day, we need a world that is free of all unethical practice. At least as doctors, we should be try as much as possible to practice ethical values.
My suggestion would be all students, whether you are going in for clinical practice, then also you need bioethics. And of course, if you're a researcher, academician, then also you would need research. So bioethics. So ethics is an add-on to your medical syllabus. It is within it. So if you were to do a little extra courses and things in that, and those who have the tendency, it's not everyone's cup of tea, but we have to be ethical. Everyone, without doubt, every person should be ethical, but some have a little more liking, so they can do other things. And what we are trying to say, as Dr. Mary pointed out, and many of our students also, they have gained a lot by doing small bioethics research, taking part, and that has made them out to be a better person too. And they have been sort of transformed, as Dr. Russell would also say, isn't it?
Yes.
Knowing bioethics transforms you too.
Exactly. And that's why we are taking this, I have spent so much of time, and we are doing so much. And I'm glad, because I told you that all of you are with MSCI. This is the only unit in the 250 units. This is the only medical student unit in UNESCO Chair's international network.
Thank you so much. And I think just adding on to something Dr. Princey also said, it does help a lot. There's so many starting points where you can get into the field of bioethics. At least I'm no expert, but just based on the little I've been able to do in the last 2 years, I've myself done the course that Dr. Russell mentioned, and it's a nice opportunity for me to also announce that we're doing it again this year. And you can please keep a check on the email servers or our social media accounts to hear more about the dates and the exact details of how you can join. And also another way of doing it is through research, because I've been a person who's always wanted to be on the intersection of research and bioethics. And that's how it all started with Dr. Mary helping me out on a project around ethics in research on pregnant women, to be very specific about that. So yeah, it's a pleasure to have all three of you, and I'm sure the participants have benefited a lot from the point of views you've put forward. And I'm very grateful for all the work you've been doing to encourage students like me, and also MSI as an organization to contribute and engage in the bioethics world. With that, we can call it an end for today. A request to the participants is to please fill out the post event form. The link is in the chat box for you to access. And thank you so much again for joining.
Thank you.
Thank you, and bye-bye to everyone. All the best to you.
Thank you,
Be
Purva.
safe
Thank
and
you,
be
Joel.
healthy.
Thank you, Purva.
Thank you.
Thank you.
Be safe and be positive.
Yes.
Thank you.
Okay, bye-bye.